see. Hey, everybody. We're going to give it a minute just to see what people filter in. It's only 3 o'clock now. Are you still on Rogers, April? Or did you get off?
No. Yeah, I had a couple days off at New Year's.
Oh, nice. Okay, good. Yeah, being on over the holidays, it's hard to juggle everything. Let's see. Okay, well, it's 3:02. And it looks like folks are still coming in. So why don't we go ahead and get started? So just so everyone's aware, the meeting's being recorded. It'll be edited and then posted on our website. So thank you, everyone, for joining us today for the monthly Tennessee Center for AIDS Research Seminar Series. Today, we're delighted to welcome April Pettit as our speaker. Dr. Pettit's a professor of medicine in the Division of Infectious Diseases and also epidemiology at Vanderbilt University Medical Center. She's also a long-time member and leader in the CFAR. She's currently director of our clinical science core. She also serves as the Vanderbilt site PI for the CFAR network of integrated clinical systems site here at Vanderbilt. And importantly, which I did not know until recently, she's also a member of the U.S. Department of Health and Human Services antiretroviral guidelines for adults and adolescents committee. April earned her MD from Wayne State University of Medicine and completed her MPH and infectious diseases fellowship at Vanderbilt University School of Medicine. And she leads a broad research program utilizing implementation science to identify optimal strategies to encourage uptake of evidence-based interventions to enhance HIV status neutral continuum of care outcomes. And she's been consistently supported by NIH, CDC, and several other funding sources. So thank you so much, April, for coming today. The title of the talk is Connection, Using Implementation Science to Develop and Evaluate a Rapid ART Initiative in Memphis, Tennessee. And we're excited to have you.
Great. Thank you very much for the introduction. Let me... All right. Do you see the full slide?
We do, yes.
Okay. So yeah, thank you, John, again for the introduction and for the invite. I am very excited that some of this data are kind of hot off the press, so I'm excited to be able to, I think this is one of the first forums in which I'll be sharing some of these. So I know that many of you are aware of the U.S. Ending the HIV Epidemic initiative, and this is kind of how this project was born. Back in 2017, after the initiative was announced, there were funding opportunities as supplements to the CFARs and eligible, and also the ARCs. So those were the eligible folks. And just quick to point out, our CFAR is currently, the the Tennessee CFAR, and we have four partners currently: the Department of Health, Vanderbilt, Meharry, and Nashville Cares. And we have been interested in expanding our partnerships to include Memphis, and this was some of the first work that we were able to do that with. So I know many of you have also seen this map. So this is a map of the priority jurisdictions identified in the EHE, National EHE Plan. And while Tennessee was not one of the states considered to have a substantial rural burden of HIV, we do have one EHE Phase 1 priority jurisdiction in Memphis and Shelby County, Tennessee. And then another part of the funding opportunity was that it was required to address at least one of the EHE pillars, so diagnose, treat, prevent, respond, and also be locally relevant. So the timing of this was great because the Memphis and Shelby County had just finished up developing their EHE plan. And these are some of the graphics from the plan. And while I do like music, I cannot read music, but I am told that these music notes represent a harmony. So I just thought that their branding was pretty cool. So, you know, the local plan, as I mentioned, did mirror the national plan. And so some of the goals from their treat pillar were to achieve 90% linkage to care in 1 month for people newly diagnosed with HIV, and to reduce disparities in linkage among vulnerable populations by 75%. And just to give you an idea, some of the epidemiology of HIV in Memphis. So Memphis is the largest majority Black city in the US. And although this study, had started back in 2018, Memphis is currently ranks first in the US among metropolitan statistical areas for HIV incidence. At the time the study started, it was hovering around 4, so has been in the top 5 in the US since the EHE initiative was announced. And these are data from 2018. These are data that we looked at to try to help us figure out which pillar had the most need to address. And so you can see linkage, retention, and viral suppression here with Memphis in red and the US overall in orange. And you can see that the biggest disparity between the US and in Memphis was in linkage. So we knew we wanted to address that pillar first, knowing that it may have downstream impacts on these other continuum of care measures. So I know many of you know what rapid ART is, but it is a health system intervention designed to facilitate ART initiation as soon as possible after diagnosis by addressing structural barriers. And it had been shown to be effective in various settings, including San Francisco and Atlanta. But as we know, the types of structural barriers that are present differ by setting. And so these types of interventions need to be tailored to each specific setting in order to be effective. And the rapid ART initiation is also has a strong recommendation in the DHHS guidelines for HIV treatment in the United States. So and these are based on clinical trial efficacy data, in addition to the effectiveness data I just showed. So what is implementation science? So it's a multidisciplinary specialty, and the crux is that trying to understand the behaviors of kind of all the groups of people involved in a process in order to understand the reasons why an evidence-based intervention such as rapid ART initiation is not taken up into real-world routine practice. So we had 3 aims in this proposal, and the EHE funding that we initially had as a supplement to the CFAR, we developed some pilot data between 2 sites that we later used to apply for a CDC grant to expand the work. And I'll be showing the results from the expanded work from the CDC project. And also want to give a shout out to Julie Dombrowski at the University of Washington, who helped make the connection between the folks in our CFAR with some folks in Memphis. She had been doing other CDC capacity building work in Memphis at the time. And Memphis had been assigned to the University of Washington regional kind of capacity building hub. That has since been realigned geographically, but I just want to thank her for that introduction and kind of getting this work started. But our first aim was to construct a comprehensive process map of the steps between a positive HIV screening test and ART initiation for people newly diagnosed with HIV in Shelby County, and using this map to identify areas in which procedure or policy changes could have the highest impact on outcomes. And there's a good publication in the BMC Health Services research that discusses the phases for process mapping. There are 5 phases, and I'll go through them here, but phase 1 is preparation, planning, and process identification. Phase 2 is data information and gathering. Phase 3 is the map generation. Phase 4 is the analysis of the map, and then phase 5 is taking it forward and acting on your findings. So in the preparation, planning, and process identification, as I had mentioned in the background, we knew we wanted to focus on the treat pillar and specifically on rapid ART initiation based on the gaps between the linkage to care in Memphis and the US. And then we wanted to next identify partners. So we had some academic partners, through our CFAR, but wanted to identify more, including in the Memphis area, and also identify community partners and then our implementation partners, including the HIV testing and treatment sites. So the academic partners are here. So this was a 3 MPI proposal with myself as the contact PI, and then we have a PI at the Tennessee Department of Health, who at the time was Meredith Brantley and is now Rob Nash. Carolyn Audette at Vanderbilt has expertise in implementation science. Ima Ahonkai, who was at Vanderbilt, has moved now to MGH, but has expertise in HIV clinical care and community engagement. Dr. Latrice Pichon at the University of Memphis, who has expertise in community-based participatory research, behavioral medicine. Peter Ribeiro, who's at Vanderbilt leading, he's a biostatistician leading the quantitative work, and then our project manager, Leslie Pierce. Our community partners included a group called Connect to Protect. They are administratively housed at St. Jude Children's Research Hospital in Memphis. And the group was initially developed as kind of a community advisory board for their adolescent trials network site, but then kind of stayed together when they moved towards developing their EHE plan and now towards implementation of the plan. And they had critical feedback in helping us identify implementation partners, reviewing study documents, and you'll see more of this later, but input on implementation strategies, and then importantly will be helping us disseminate the results. In order to identify our implementation partners, we utilized surveillance data from TDH. So these were data from the year prior to our EHE supplement proposal. And we looked at all the numbers of people newly diagnosed with HIV kind of by facility type. And you can see here that 24, so the kind of the two highest outpatient type settings were the public health, municipal health department, and then other outpatient clinics. There are also not insignificant numbers of people diagnosed from correctional facilities, hospital and ER settings, and blood bank, but we really wanted to start our focus within kind of outpatient settings with the hope to expand to some of these other types of settings in the future, as the structural barriers and kind of the strategies will probably differ for some of these other types of sites. And then similarly for our implementation partners who are doing HIV treatment, we looked at people newly diagnosed with HIV who were over 21 years of age, and that's because in Memphis, there was already a rapid ART program called the SMILE program, in which people who were 21 or are 21 and younger are already rapidly linked to care at St. Jude. And so that we wanted to look at the data for people over 21. And we wanted to really focus first on Ryan White clinics. But as you can see, there were kind of two clinics that had both high numbers of people overall, as well as per site. And this is the kind of the final group of implementation partners. So Regional One Health is affiliated with the University of Tennessee. So it's an academic kind of adult HIV-based clinic. St. Jude Children's Research Hospital, also academic, but more pediatric HIV clinic. Of course, the health department. And then Christ Community Health Services, which is a faith-based, federally qualified health center that has several sites across the city. And then finally, a community-based organization that is part of Le Bonheur Methodist, who is doing HIV testing in the community. So once we kind of identified our process and the partners, we next moved to information gathering, and we used a lot of different methods to gather information about this process. We actually went to the clinics and walked through the clinic as if we were a patient. So we would walk in, go to the front desk, and we would chat with the front desk staff and ask things like, what's required for someone to check in? They have to have an ID or whatever, whatever else. What happens if they don't have an ID? Then where do they go? And kind of walked through the clinic as if we were a patient ourselves. So we did kind of informal interviews like that. And then after these walkthroughs, we did some multidisciplinary meetings where we had kind of everyone in the clinic, and we would, ask clarification on things that we saw, and discuss, kind of confirm what we saw or get clarification. And then we also collected documents that patients were required to fill out, or handouts that they received, in order to really just get an in-depth kind of map of what was happening from the patient perspective. So I know that this font is small, so it's not meant really to be read, but this is an example. This is actually an example of the final process map. Usually an initial process map is more like something like doodling on a paper, or even using like sticky notes and moving things around. Um, as I mentioned at some of the points, if a requirement wasn't met, then what happens? Um, and then phase 4 is analyzing the map. And we used the CFAR framework as a guide for systematic assessment of barriers and facilitators to this rapid ART process. As I mentioned, usually the draft process maps are like sticky notes or doodling, but there are software that you can use. Microsoft Visio is one. And then the final map, we present the draft maps back to the sites and say, is this an accurate reflection of the process? And also to the community, to make sure that we were really accurately depicting the process. So I have one slide for each of the CFAR domains, and then some of the constructs that came out. So as far as intervention characteristics, we found that people wanted a centrally located and kind of easily accessible place for information to be accessed. And they also wanted program branding in English and Spanish. We found that we heard that people really were struggling because they were having to balance, new programs such as this with other internal programs. For example, some of the sites had benchmarks for client cycling time. So like how long a patient stayed, in the clinic. And so just having these, kind of competing needs within the clinic, we found that providers and staff and clients really thought that the quality and validity of the data supporting rapid ART was strong, but we found that perceptions differed by provider, and specifically some of the providers who have been practicing longer tended to be a little more skeptical and concerned about resistance. I think that this is less of an issue now, but when the project first started, we definitely found that perceptions differed by provider. So as far as the outer setting, we found, people told us repeatedly that patients really wanted rapid ART initiation, but that often social determinants of health or stigma or trauma kind of take priority, understandably. We heard that their lack of communication and networking across HIV testing and care and service organizations was a big barrier. We heard that, a facilitator was, as I mentioned, kind of successful citywide initiatives elsewhere. Additionally, facilitators included the national and local EHE plans, as well as the DHHS guidelines that prioritize rapid ART. But we heard that there were, people wanted more kind of incentives or mechanisms to require rapid ART initiation. Moving to the inner setting, there was a lot of stigma, and the type of stigma kind of differed based on the organization. So stigma was one of the things we heard repeatedly. Specifically with a government agency, people feared that CPS was going to be called on their children. In a dedicated HIV clinic, people were concerned with kind of being, their status being disclosed. And then in a faith-based institution, there was some, we heard about stigma related to either gender minority status or LGBTQ identification. We heard that there were barriers as far as policies related to hiring and salary. And I think it's also important to note that this project kind of spanned COVID also, which I'll get to in a minute. But one example was during COVID, there were temp workers at the health department that the long-term staff knew had higher salaries than them. So there was a lot of issues around that. Staff turnover, burnout, low morale, which is persisting. I've mentioned kind of the lack of networking and communications. As far as facilitators, leadership were engaged. Rapid ART was viewed as important. People viewed the technical assistance from the State Department of Health, the CFAR, AETC as positive, and pharmaceutical samples availability was there. Whether it was being accessed or not, it was a different story. Barriers as far as implementation climate include, as I mentioned, competing priorities and also COVID and MPOX happening. Some of the sites do not provide HIV care. So if someone was tested, they couldn't link them to care at their own site. And some of these sites are now looking at trying to offer HIV care. People specifically wanted goals and they wanted feedback towards the goals. So knowing how long it was taking people to get linked, from each organization, and how they were progressing over time. There were issues related to lack of staff space, workflow disruption, incentives, and then lack of other types of resources like flexible scheduling templates, lack of kind of tangible resources, including rapid HIV confirmatory test kits, and then ART starter pack samples. Not that these weren't available, but they weren't always being accessed. Characteristics of individuals. So we found, as I had mentioned, that, trainings were readily available, but they were not being accessed, and people kind of wanted one central place they knew they could go to get these trainings. And then, as I mentioned, providers were generally enthusiastic. And then identification with organization kind of differ based on the organizations, and staff turnover and morale kind of differed based on the organization as well. And finally, process. So things that facilitate, as I mentioned, the State Department of Health, the CFAR, the C2P Community Coalition, the EHE Implementation Planning Group, having leaders at each site. These were all in place and considered to be facilitators. People wanted a venue to share their successes and challenges and to be able to kind of refine the rapid ART model. As I mentioned, they wanted, goals and feedback. And as far as planning, this had been going on for several years. So that was considered a facilitator. So phase 5, taking it forward, as I mentioned, just basically acting on the findings from the process map, which leads me into our aim 2. So our aim 2 was to use the data to take it forward, use the data we collected from the process mapping, from the interview, from the tables that I showed, kind of analyzing it by the CFAR, and working with the sites to develop a model that was, customized specifically to the facilitators and barriers at this setting. And there were, again, several methods that we used to identify strategies. So strategies often came up kind of organically as we were doing the process mapping. So talking to people and learning about the process, they would say, I wish we did this instead. We also had input from the community as far as what types of strategies might work best. There were some strategies that were already in the local EHE plan as well. And then we used something called a modified conjoint analysis, in which, and this is just an example for one of the sites, we kind of took the top 10 barriers that we heard most frequently, and we would assign them basically like a different colored, either sticky note or a marker. And then we would ask people to rank them based on feasibility or importance. So low for both, high for both, low feasibility, but high importance, high feasibility, or low importance. And then we kind of narrowed down our discussions on strategies to those that fell into that kind of right upper quadrant that were considered to be highly feasible and highly important. And what we ended up developing was basically an SOP that outlined several things, some of which I won't get into in depth for the sake of time, but the rationale for rapid ART, the eligibility, the operation, so specifically, laboratory issues around laboratory testing, rapid ART regimens. We included some proposed evaluation metrics. We included a section on training and included, the links to the trainings. We also included and this is a critical kind of part of the SOP, but a section on site communication where we listed the contact information for kind of the leader at the site, as well as the a leader for kind of the field staff, so that, and this is updated every quarter or sooner if needed, depending on staff turnover, so that people knew who to go to at each site, specifically to do kind of a warm handoff of a patient from an HIV testing to treatment site if those sites differed. We did, as I mentioned, we heard a lot about stigma, but in our modified conjoint analysis, stigma came out as something that was highly important, but was considered to be less feasible to change. And because it was kind of the most frequent barrier we heard, we didn't want to not address it. So we do have a section on that, which I'll get to in a minute. And then, acknowledgements, references, and then some appendices with kind of risk assessment tools and other things. And this SOP can be found on the End HIV 901, which is their EHE plan's name website, so everyone can access it. As far as stigma reduction, so as I mentioned, it came out as a very strong and frequently discussed barrier, but considered, less feasible to change. Dr. Pichon at the University of Memphis had developed a photo voice project where she gave people living with HIV cameras and created kind of storyboards, including photos. And this is just an example of one, quotes. And the project was called Snap Out Stigma, and there are some publications on it. But we offered the sites kind of reprints of these boards that they could use as kind of environmental change, so hanging on the walls in the clinic. And one of the sites actually also used them during trainings on stigma, so understanding how patients experience stigma. And then we also developed a logo. So we partnered with a local branding and consulting company, Angelic Branding, owned by Janae Woods. And we basically crowdsourced ideas for a logo and offered a Visa gift card for folks for the concept that was chosen to move forward. And I'm not going to show all of the concepts that were submitted, but this I think we had about 5, but this is the one that was ultimately chosen, and the concepts were voted on by our community and implementing partners. So this is where our connection logo that I had on the initial title slide came from. So it's just kind of cool to see, submitting this concept to the branding company and then developing our final logo. That was a really fun part of the project. So we have that available in Spanish and in English. And then importantly, we also developed a community of practice. So a community of practice is defined as a group of people who interact regularly around a shared interest and develop a shared knowledge and resources. These occur quarterly in person at, quote, a neutral location in Memphis. So we've been holding them kind of not at one of the sites. And at these meetings, each site has an opportunity to, discuss staffing changes as well as other successes and challenges related to rapid ART initiation in their organization. And it's a chance for people to network and kind of get to know each other. And these are ongoing. So that kind of sums up the development of the model or the intervention. And then these are very new data and these are the data that I haven't yet presented, but these are the evaluation data. So we measured outcomes, during the pre-implementation, implementation, and post-implementation periods, and using these as feedback to help refine our strategies. So these are some basic demographics. So of people newly diagnosed with HIV in the pre-implementation period, which is longer, currently than the post-implementation period, but implementation occurred around May, June 2024. And there were 278 folks total, 203 in the pre-implementation period and 75 in the post-implementation period. And there were no differences based on either age, sex, or race, ethnicity. there is a difference in HIV transmission factor. This is largely due to unknown. This is a longstanding issue with the surveillance data from Memphis, and essentially these data get updated in EHARs as time goes on. And so the unknown, as you can see, there's basically flipping from either from unknown either to MSM or heterosexual contact. So I don't think that this is due really to differences in the populations as much as it is an artifact of the surveillance data being updated. And then you can see the testing site, so how many people newly diagnosed from each testing site, from each treatment site, their baseline CD4 counts, and their baseline viral load. And there was no statistically significant difference in any of these, although you may say there's a trend in differences in the HIV testing site, largely due to the health department ramping up their testing, and specifically shifting the health department shifting towards systematic use of double rapid. They had been doing rapid screening, but not rapid HIV confirmatory testing. So they were really ramping that up during that period. So we used the REAIM framework, which is another implementation science framework that developed to improve the adoption and sustainable implementation of evidence-based interventions in a wide range of settings, including health and public health settings. We did not focus on all of the domains in this framework. But I will outline. So obviously we wanted to look at effectiveness, and we define this as the median time in days from a positive confirmatory test to linkage, which was defined as the first CD4 or HIV viral load in the surveillance data. We did not have access to ART initiation data, which is a limitation of the surveillance data. And then we looked at median time in days from a positive HIV test to viral suppression. And this is just the crude kind of unadjusted temporal trends in time to linkage by calendar month. And you can see that there was not a ton. This was statistically significant in the adjusted analysis, which I'll show in a minute, but there wasn't a big change, as big of a change maybe as we would have wanted to see in linkage to care. It did drop from 22 to 18 days, and clearly we'll continue to monitor this, and it may improve hopefully more over time. But this is the Kaplan-Meier, and you can see that the adjusted hazard ratio was 2.22 in favor of the post implementation period as far as time to linkage. And this is adjusted for age, sex, race, HIV transmission factor, and site. We did see a much more robust improvement in viral load. In time to viral suppression. You can see here the crude time to viral suppression decreased from 119 days to 62 days. So, about a 50% improvement in time to viral suppression. And this also bore out in the adjusted analyses with an adjusted hazard ratio of about 3. So some of the work that's ongoing is related to the other REAIM domains. So looking at staff satisfaction and acceptability, looking at fidelity to the SOP, and then also assessment and incorporation of the model into routine practice. Dr. Pichon and her team in Memphis have been conducting in-depth interviews to try to understand this better. And then, of course, maintenance, changes in effectiveness over time. Looking at using the surveillance data, we will continue to do that to see if, we can, one, at least maintain the improvements that we've seen, or two, hopefully see continued improvements if there's, more of a lag in the surveillance data from implementation. So some of the limitations, obviously, this was a non-randomized observational study, and the outcomes rely on the public health surveillance data, which reflect labs captured doing routine care. So, we don't have systematically a viral load, every month on every patient. It's just kind of, what happened naturally is what we're using. I would also argue that these are strengths of the study, though. Generalizability. So while the results, or, the specific model that we used here may not be able to be picked up and used somewhere else, I think the methods that we used certainly could be used in other settings to develop their own kind of contextually appropriate intervention. And then right now, and this is the last limitation, here's something I hope we get to learn from the interviews, but it's unclear kind of the impact of the individual components of the intervention on the outcome. One of my theories, and we'll be digging more into the data kind of site by site, but I think that the reason that we have seen more improvement in viral suppression is that the time from when people get to the clinic and get started on ART improved more than the time that, before people got to the clinic. So I think there's probably more we can do, getting people from a positive test to the clinic, but we're doing a pretty good job once they get to the clinic of getting them on ART. So some future directions, we would definitely like to scale out to additional HIV testing and care facilities, and also, potentially think about the other settings I mentioned initially, including correctional facilities, hospitals and ERs, as well as blood banks. We would like to expand to people living with HIV who are re-engaging in care. Certainly, we could adapt this to develop a similar model for people who test negative for HIV and should be initiated on PrEP. And then also expanding the model across the state. Although, as I mentioned before, the structural barriers in Memphis are unique to Memphis and may not be the same across, but I think, we could adapt the intervention to work elsewhere in the state. So there are innumerable people to thank, including our funders, the NIH, the CFAR, and CDC, our community partners, our implementing partners, the Department of Health, Dr. Pichon and her group at the University of Memphis. I think that's it. So I'm happy to